Hello. Bismillahirrahmanirrahim.
Assalamu alaikum. Good morning, everybody. Today we will be presenting intramedullary nailing of radial neck fractures in Jordan Hospital under the care of Dr. Kamel Afifi, the head of the Orthopedic Surgery Department. I'm Dr. Abdul Qadir Shaban, will be presenting his cases on his behalf. The objectives of this lecture is to talk a little bit about the radial neck fractures and the treatment modalities currently in use. Then we will talk about the Methyzo technique in radial neck fracture treatment, and we will review our data and present few of our cases. To start with the radial neck fractures, they are relatively common fractures around the elbow in the pediatric age group with a median age of around 10 years, but they are less common in the adult age group. Mostly they are grouped with the radial head fractures and associated with it most of the time. The mechanism of such fractures usually either by falling on the outstretched hand with valgus loading of the elbow, or with the elbow extended and the forearm pronated, and may lead to other associated injuries around the elbow, such as other fractures, coronoid, olecranon, or soft tissue injuries such as the LCL and MTL. The classification system currently in use for the radial neck fractures in the pediatric age group, it mainly emphasizes on the angulation of the fracture of the radial neck fractures, either such as the Judet classification or the O'Brien classification, with the cut point of 30 degrees to be acceptable in such fractures. Sometimes in early or in very young pediatric patients, you can accept up to 45 degrees. But in the adults, the classification system for the radial neck fracture is a very old one. Starting in 1926, first described by Cutler, which simply classified such fractures usually of the radial head as non-displaced, displaced, or comminuted. But the most well-known one is the Mason classification put forward by Mason in 1954, but didn't include the radial neck within his classification, had only 3 types, and didn't delineate the displacement amount. Later on, it was modified multiple times, although remained under his name, such as by Johnston in 1962, then by Broberg in 1987, who added the radial neck fractures into this classification system. And still the classification is improving. Nowadays, the latest is the Mayo classification, which includes a prefix that indicates other associated injuries with the radial head and neck fractures. Now, the treatment modalities range as all fractures are treated, from conservative management till the most extensive treatments of radial head arthroplasty. Usually, the conservative is for less than 30 degrees in pediatric age group, especially used. More, if it's not less than 30, then you go for closed reduction if it is stable. Otherwise, you go for open reduction, which is indicated for advanced stages in adults, or inadequate reduction, or inability to do closed reduction in pediatrics. Now, the complications of such treatment, even the conservative management, includes the stiffness around the elbow joint with prolonged immobilization, or even loss of the reduction with time. With the operative management, you can cause severe damage around the radial head and neck area, such as the osteonecrosis if you injure the blood supply, nerve injury, especially to the posterior interosseous with the approach of the open reduction, physical arrest in the pediatric age group. The most severe is the synostosis and loss of function. Other common complications such as the infection and the hip ossification also are included. Now, here's why Jean-Paul Methyzo, a French surgeon, proposed in the 1980, to be specific, his technique for treatment of radial neck fractures in pediatric age group. Followed by multiple studies he presented by himself in 1983, 88, and 93, first described for treating pediatrics only, which included in advancement of retrograde K-wire through a distal radial opening till reaching the fracture site around the radial neck, impacting the K-wire in the fractured piece proximally, then rotating it 100 degrees to maintain the reduction. And now, since 2015, it started in the literature being reported in the treatment of adult radial neck fractures, first as a case report, then as a case series, and lately also suggested some modification for the classification system for the radial neck fractures in adults. The benefits of such a technique is being minimally invasive with less complication, allowing early range of motion and less invasive to the area around the fracture. It has a fast learning curve, and the studies all show promising results with better outcome than other treatment modalities. Now, our technique for using the Methyzo technique is that our patients present to the ER with the fractures, either pediatric or the adults. We usually admit them on the day of presentation, especially for monitoring the compartment syndrome in pediatric patients. Then, as soon as possible, either on the same day or the next day, under general anesthesia in the supine position on the radiolucent armrest, we apply a tourniquet, but we do not inflate it, just in case if we want to, or we had the need to go for open surgery, and we scrub and prepare the whole upper limb. Two entry points through the distal radius were proposed, one on the dorsum and one on the lateral. We usually go for the lateral entry point. We open it using the owl, isolating and protecting the superficial radial nerve, which is very important not to injure such a nerve. Then we advance a titanium elastic nail, sizes ranging from 1.5 to 2.5, depending on the age of the patient, till reaching the fracture site, impacting it in the radial head and neck piece, then rotating it to maintain the reduction. Then we check the stability of the reduction after that under fluoroscopy. Post-operatively, we apply a cast for 2 weeks. Then we monitor the patient overnight for pain management and also for the compartment syndrome. Then we discharge the patients the next morning. We follow them at 1 week to do dressings. On the second week, we do an X-ray to make sure that the reduction is maintained still. Then we remove the stitches and the cast, and we start passive flexion and extension movement to decrease the risk of stiffness around the elbow joint. Then by 4 weeks, we start the pronation supination movement. At 8 weeks, we redo the X-ray to make sure that everything is in place. Then in the pediatric age group, we plan for the removal of the nail. Now, between 2015 and 2020 in Jordan Hospital, we treated 11 patients using the Methyzo technique, 7 of them being pediatric patients, 4 of them being being adults. One case only had an associated olecranon fracture. One case was the one with the olecranon fracture was caused by a direct trauma to the elbow joint. The other cases were all falling on outstretched hand. The average age for the pediatric patients was around 9 years, ranging from 5 to 14. The adults had a range of around 38 years, ranging from 18 to 52 years. In the pediatric age group, 5 patients had the Judette type 3 fracture types, and 2 patients had the Judette type 4. With the adult patients, half had Mason 2 and half had Mason 3. We followed them up for an average of 1 year. Usually, we give them appointments till the 8 weeks, but the adult patients keep coming back for checkup, ranging from 6 months to 1.5 years. For the outcome, all the pediatric patients had radiological union by the 8 weeks with full range of motion. The adult groups also had radiological union by 8 weeks, but one patient had decreased final range of motion of around 10 degrees of pronation, which did not make a problem for his daily life. Our first case being presented is a 7-year-old male falling down with direct trauma 2 hours prior to presentation to our hospital with elbow pain, limited range of motion, swelling. Upon doing the X-rays, we see that there is a radial neck fracture with angulation of around 40 degrees, 45 degrees, and associated olecranon fracture. So it is a Judette type 2. He was taken to the operating theater and underwent the treatment using the Methyzo technique for the radial neck fracture. As you can see, the reduction is within acceptable range, and percutaneous or close reduction and percutaneous fixation for the olecranon fracture. This is the final result after the removal of the elastic nail around 3 months post-surgery, which showed complete healing and no deformity at the fracture sites. The second case is for an 18-year-old female falling on outstretched hand. The same presentation, elbow pain, limitation of range of motion, swelling, and intact neurovascular examination. Upon the X-ray came with Mason type 3 fracture of the radial neck with some comminution. Taken to the OR and underwent the closed reduction and treatment using intramedullary nail by Methyzo technique. And as you can see, the reduction is excellent. And on follow-ups after 3 months, also had complete consolidation at the fracture site with the elastic nail still in place. Of course, we do not remove them for the adult patients if they are not disturbed by it. Now, in conclusion, the radial neck fractures are common fractures in pediatric, less in adult. The open reduction or even the conservative management carry risk for many complications. The Methyzo technique, minimally invasive, safe, flexible. You can use it also with assisted means to reduce the fracture site. It is first described for pediatrics, but started to find its way in adult practice and appears to be a safe option. Thank you.
Good morning, all. On behalf of Dr. Jihad Ajlani, I'm Mohammed Lissi, a fifth-year orthopedic resident at Jordan University Hospital. Our talk now is about management of hip fracture among elderly patients at Jordan University Hospital. As an introduction, hip fracture care continue to improve secondary to international audit and optimization of hip fracture management. Hip fractures are exceedingly common presentations with approximately incidence per year about 65,000 in UK, 300,000 in the United States, and roughly about 2 million worldwide. This figure is projected to increase threefold by 2050. This article is a cross-sectional study compared the practice of elderly hip fracture management at Jordan University Hospital against the practice recommended by American Academy of Orthopedic Surgeons, AOS. The purpose of this study was to determine how closely our institution treatment pathway followed the AOS guidelines in order to improve the quality of delivered care. Just to note that this study has published in June 2020 at Current Orthopedic Practice Journal. We retrospectively reviewed the records of patients who were admitted with a diagnosis of hip fracture, either intertrochanteric fracture or femur neck fracture, within 1 year between October 2017 and October 2018. We excluded all patients who are under the age of 65, as the definition of elderly people by AOS is either 65 or above. Also, a patient who had a high energy mechanism of injury, multi-trauma patient, or who were transferred from another hospital, or who had a pathological fractures also were excluded. We collected the data starting by the patient demographics, including age, gender, weight, height, as well as patients' comorbidities. In addition to the data in the preoperative phase, intraoperative phase, and postoperative phase according to the AOS guidelines. The preoperative data that we collected is starting by the diagnostic imaging, either radiographs only, CT scan or MRI, the use of aspirin or clopidogrel, the time between admission and surgery, the cause of delay if there is any delay after 48 hours, the use of traction in emergency room or in the floor, the mode of preoperative analgesia. The intraoperative data that we collected included mode of anesthesia, type of fracture, type of fixation, and use of cemented or cementless arthroplasty, use of unipolar or bipolar head, and finally, the surgical approach in cases of arthroplasty. Post-operatively, we documented the venous thromboembolism prophylaxis, mode of post-operative analgesia, nutritional assessment during hospital stay, post-operative physical therapy, and continuation of physical therapy after discharge. Hemoglobin level before blood transfusion, post-operative prescription of calcium and vitamin D, evaluation of osteoporosis by DEXA scan, and finally, the length of hospital stay and death within 6 weeks. Now, the results. Over the 1 year, 148 patients were admitted to the orthopedic department due to hip fracture within 1 year. 35 patients were excluded according to the exclusion criteria. The mean age of our included patient was 77.5 years. 52% of those patients were female, and more than half of our patients had 2 or more medical comorbidities. The mean length of hospital stay at our center was about 7 days. 9 patients died within 6 weeks of admission. The prevalence of each fracture type, according to this table, most of our patients had unstable intertrochanteric fracture, and 1/4 had stable intertrochanteric fracture, and another 1/4 had unstable femoral neck fracture. Just to note that over this year, of the studied year, there is no stable femoral neck fracture admitted. Now, just to discuss our institutional pathway versus the AOS recommendation. These guidelines or recommendation adopted by AOS in September 2014 and updated in April 2019. Just to know that the strength of recommendation that I will mention is classified as strong, moderate, and limited according to the study, the strength of study that the recommendation was built on. Starting by imaging, AOS recommend use of MRI as the advanced imaging of choice for diagnosis of a presumed hip fracture that not apparent in the initial X-ray. In our study, 3 patients had an occult fracture, but we diagnosed them by CT scan, but not MRI. We didn't use MRI. In our opinion, this can be explained by the feasibility of CT scan in the emergency room. MRI, to do MRI at our center, the patient have to be admitted and to arrange MRI next or second day of admission. Regarding the preoperative analgesia and traction, AOS has strong evidence that support regional analgesia for improved preoperative pain control in patients with hip fracture. Regional analgesia was not used in any of our patients. We mean here regional analgesia by femoral block or fascia iliaca ultrasound guided block. This service is not available at our center of the emergency department. Moderate evidence does not support routine use of preoperative traction for patients with hip fracture. Preoperative traction was not used in any of our studied patients. Regarding the timing of surgery, the AOS recommend with moderate evidence that the surgery for hip fracture should be done within 48 hours of admission that is associated with better outcome. 83% of our surgeries were done within 40 hours of admission. 18 surgery only were delayed after 48 hours due to patient medical unfitnesses, and only 1 case due to clopidogrel anticoagulation. There is limited evidence supports that hip fracture surgery should not be delayed for patients who are on aspirin or clopidogrel. Although 54 patients of our studied population were on aspirin preoperatively, none of them had a delay of surgery due to use of aspirin. 17 patients were on clopidogrel preoperatively, only 1 patient had a delayed surgery due to its use. Regarding the anesthesia, the AOS concluded that there is similar outcome between general and spinal anesthesia for hip fracture surgeries. The most commonly used mode of anesthesia at our center is spinal anesthesia in about 86%. Regarding fixation or treatment of unstable femoral neck fracture, the AOS recommend arthroplasty for unstable femoral neck fracture and supports the outcome between unipolar and bipolar heads in cases of hemiarthroplasty are similar. Of 113 patients included in the study, 29 diagnosed with unstable femoral neck fracture. All were treated with hemiarthroplasty. About 90% of cases of hemiarthroplasty cases at our center underwent surgery with bipolar head, which is more costly. Moderate evidence supports the preferential use of cemented femoral stem in patients undergoing arthroplasty for femoral neck fracture. We use cemented femoral stem in 28 out of 29 patients. Moderate evidence support benefit of total hip arthroplasty in properly selected patients in cases of unstable femoral neck fracture, but none of our patients underwent total hip arthroplasty. AOS supports that the posterior approach is associated with higher dislocation rate for treatment of displaced femoral neck fracture. The usual approach at our center is direct lateral transgluteal approach, and we didn't use the posterior approach for any case of hemiarthroplasty. Regarding fixation of stable intertrochanteric fracture, the AOS support use of either sliding hip screw or cephalomedullary device. Both are comparable for stable intertrochanteric fracture. From all patients, about 31 had a stable intertrochanteric fracture. 93% of them treated with the least costly dynamic hip screw or sliding hip screw. Only 2 patients had intramedullary nails. Most of our patients we studied during that year had unstable intertrochanteric fracture, and the AOS support using cephalomedullary device for unstable intertrochanteric fracture. About 86.7% treated with cephalomedullary device, and only 13% treated with sliding hip PSO, despite they are unstable intertrochanteric fracture. Regarding venous thromboembolism prophylaxis, moderate evidence support use of prophylaxis for venous thromboembolism in patients with hip fracture. All of our patients receive post-operative prophylaxis for venous thromboembolism. The AOS has strong evidence that support a blood transfusion threshold of no more than 8 in asymptomatic patients with hip fracture post-operatively. Nearly half of our patients received blood transfusion. The mean threshold for blood transfusion was 8.4. Regarding physical therapy, there is strong evidence support intensive physical therapy after discharge to improve the functional outcome in hip fracture patients. About only 1/4 of our patients continued their physical therapy at home. Regarding the nutritional supplementation, there is moderate evidence support that the post-operative nutritional supplementation reduces mortality in hip fracture patients. Less than 1/3 of our studied population underwent nutritional assessment and support during their hospital stay. Regarding pain management, the AOS recommend multimodal pain management after hip fracture surgery. Our modes of analgesia at Jordan University Hospital include paracetamol, non-steroidal opiates, and local anesthesia infiltration at the end of surgery. About 80% of our patients received at least 2 types of analgesia, either paracetamol with non-steroidal or paracetamol with opiates, and another 15 patients received another mode of analgesia, which was local analgesia infiltration at the end of surgery. But none of our patients received another mode of analgesia, such as regional or epidural anesthesia. Regarding vitamin D supplementation, moderate evidence support use of supplemental vitamin D and calcium after hip fracture surgery. Vitamin D and calcium were prescribed to less than half of our patients during the post-operative follow-up. Regarding osteoporosis evaluation and treatment, the AOS support that the patient with hip fracture should be evaluated and treated for osteoporosis after sustaining a hip fracture. Only 10.6% were evaluated for osteoporosis by DEXA scan at our center. So to conclude, the protocol of treatment of elderly hip fracture at Jordan University Hospital is reasonably compliant with the AOS guidelines. The rate of compliance can be increased by adopting the following advices: using of the MRI, starting by using of MRI as an imaging modality of choice to diagnose occult hip fracture, integrating the regional analgesia service in the emergency department, using the lower cost unipolar femoral heads for hemiarthroplasty cases, decreasing the threshold for blood transfusion to 8 or less in asymptomatic patients, increasing awareness of patients and family about benefit of intensive physical therapy after discharge, encouraging inpatient nutritional assessment and support, including other modes of analgesia to local pain management, a protocol prescribing vitamin D and calcium on hospital discharge and during follow-up visits, the increasing evaluation and treatment of osteoporosis after a fracture. Thank you.
صباح الخير للجميع، يعطيكم العافية. I'll talk about the scaphoid imaging. I chose this subject because we still see a lot of missed cases and undertreated cases. And everybody knows the financial burden and in addition to the absence from work or changing lifestyle after missed scaphoid injuries. 80% of scaphoid fracture constitute about 80% of carpal bone fractures. The mechanism usually is a fall on dorsiflex wrist and with radial deviation. Usually it's affecting young adults, even sometimes adolescents. 70% occur in the waist of the scaphoid, 20% in the proximal pool, and 10% in the distal pool. Early diagnosis is empirical or is very important for not to undertreat patients, which lead to complications, and not to overtreat patients with unnecessary costs and absence from work. In a survey of 107 patients, 107 hospitals all over the world from 7 continents, the questionnaire was what guidelines or what protocol you use for acute wrist injuries to diagnose scaphoid fracture. Only 7% has a consistent or identical strategy for diagnosis of scaphoid fracture. Most common one was used is the 4 views acutely, which is repeated after 14 days. MRI is the second most common modality which was used for diagnosis of scaphoid fracture. Starting with the acute injuries for the wrist joints, the standard views that we use for scaphoid diagnosis, it is the 4 views, the PA view, the PA with ulnar deviation, the lateral view, and the semi-pronated view. These views are necessary and mandatory to do in acute scaphoid fracture. As we will see here, this sign, it is, I think it's become historical. It is called a scaphoid stripe sign, which is the radiolucent part, which is within the arrow here, which is normally present in scaphoid injuries, or you cannot see it, which is sometimes in some days back was considered as a diagnosis of scaphoid fracture. But I don't think anybody, including me, looking for the signs nowadays. The ulnar deviation view, it is really very important. If you see here on the right side here, this X-ray does not show the fracture, but when you do ulnar deviation view, PA with ulnar deviation, the fracture is much more clear than you can see it here in the standard PA view of the wrist joint. And also here, if you can see it here, it is the fracture is not that much clear, but with the ulnar deviation also it is much more clear. In meta-analysis of several large series, they found that 16% of acute scaphoid fracture was not diagnosed on the initial X-ray. Fracture might take 1 to 2 weeks to come to appear on the fracture site, which is usually due to first stage of healing is usually some bone resorption around the fracture site. Secondary images. When you have the initial X-ray done at the time of the injury, it was normal. When you do the 4 views and it was normal, you have the secondary images. The most common which is used is the secondary X-rays 14 days later. And you carry the patient usually at the acutely, you treat the patient as he's having a fracture, bring him back in 2 weeks and re-examine him and X-ray him again. But in several studies, they found that there poor inter-observer reliability, not more than 50% it is reliable to diagnose scaphoid fracture in the second visit. It may result in a unnecessary casting. If the patient come back to you and you examine him, there is some signs of scaphoid fracture, you X-ray him, still the X-ray is negative. What to do now? You all are in a dilemma. You discharge the patient, you have no fractures, or cast him again, or do to other modalities. And this, if you cast him again and not doing further studies and you stick to the X-rays only, you might cast the patient again unnecessarily, and which affecting the activity of daily living and absence from work. Secondary X-ray, you can see here in the AB, there is no obvious fractures, but when you go 14 days later, you can diagnose it, and it might appear. And as we said again, there is also false negative results in the second visit with a poor inter-observer consistency. In the study, they looked at two things: physical signs, specificity and sensitivity, combined with the X-ray. They found that tubercle tenderness, scaphoid tubercle tenderness, specific in about 75% of cases and sensitive in 95%. Snuff box tenderness is the weakest sign. It is 30% specific and 85% sensitive. Compression test or axial loading, which means that you press the thumb longitudinally, axial load in the thumb. It is 30% specific and 43% sensitive. But the results combining these signs with the X-ray there is a significant difference from the MRI finding, which means that the MRI is much more accurate in diagnosing X-ray, even though you combine these specific signs and the imaging. Other modalities, I don't know if anybody using it here. It is the high spatial resolution sonography. You can see the scaphoid, and you can see the disruption in the fracture. Also, you can see I'm not an expert in ultrasound. You can see if you do the ultrasound through the snuff box, you can see a fusion in the radiocarpal or the STT joint of the wrist joint, scaphoid trapezoid joint. You can see fusion, which is diagnostic of scaphoid. And they claim it is much more sensitive than the plain X-ray in acute fractures. But the advantage of this one, it is non-invasive and safe. It has low cost. It is available, it's available all the time. It is a short procedure in an expert hand. But the disadvantage is still it is an operator dependent and needs high expertise to do such a modality of diagnosis. It's only assess the dorsal scaphoid waist. You cannot see the distal pore and you cannot see the proximal pore of the scaphoid, and you might miss other injuries of the wrist joint, including the scapholunate ligament or other occult fractures. Bone scan, which gained a wide popularity and some time. The advantage is it is highly sensitive. It is 94 to 100% if you have a positive bone scan. It performed in patient with a cast. You can do it in a cast. Sometimes the X-ray with a cast is really very difficult to interpret, but the bone scan, you can do it easily. But the disadvantage, there is a high false positive result, exceeding 25%. It needs 3 days to reach its maximum power, because the bone scan depends on the blood flow to the injured area. And you need 3 days to have the maximum blood flow to the injured scaphoid to have a clear indication by the bone scan there is a fracture. According to this, it is a very good negative test, because once it is negative, you rule out fracture, and also you rule out other injuries of the wrist joint. But if it is positive, it is very non-specific. Very non-specific. It diagnoses an injury, but does not diagnose a fracture. You cannot differentiate between this is an injury, scapholunate, it's just bone contusion, bone edema. You cannot differentiate it on the bone scan. As we see here, you just have the increased uptake. As you know, the bone scan measures the activity. It does not give you an anatomical diagnosis, just give you a functional diagnosis. So it is highly non-specific. It is good negative again, but it is a bad positive test. CT scan, it is one of the most important modalities for diagnosis of acute scaphoid fracture. It detects occult fracture. It's better determine the displacement, and it's better assist the healing. As we see here, this normal X-ray, but you go to the CT scan, you can diagnose it easily. And this is the most modality I use in acute scaphoid fracture when we have a normal X-ray. As also, it is more available than the MRI. It assists the displacement. It's very important. If you see here the X-ray here, you can see that there's a minimally displaced fracture of the scaphoid, and all views epilateral and even the ulnar deviation. But when you do the CT scan, you can see how much is displaced. If you treat the patient on this one, on this plain X-rays only, this patient is candidate for, according to the X-ray finding, candidate for conservative management. But when you do the CT scan, you can see that he is not candidate because it is displaced fracture. Also, it is a very good modality for assessing the healing process when you have a patient with a healed scaphoid fracture. Sometimes on the X-ray you get confused. You sometimes still have some discontinuity on the cortical part of the scaphoid, but when you do the CT scan, you can see the trabeculae across the trabeculae of the bone, also the continuity on the cortex. So it's better to assess the bone healing. The most sensitive one may be the early MRI. Decrease signal intensity on the T1, as we see here. As we see here, the plain X-ray is normal, but we can see here decreased signal intensity on the T1 or increase on T2. And if there is a diffuse edema of the bone, it's not a fracture, it's just a contusion. So it is a very good modality for the diagnosis of the scaphoid fracture. Now, sometimes the one might think that, is it worth to do an MRI, which is a costly, in comparing it with the X-ray and casting and repeat it in 14 days? They found that there is no statistical significant difference in the total cost, either direct or indirect, between the two groups. But the benefit is less cost days. If you have a patient who came to you with signs of scaphoid fracture, you X-ray him is normal, you do an MRI, he is diagnosed for scaphoid fracture, you take the patient to the treatment of scaphoid. If it is normal, there is no need for casting, just maybe simple wrist splint is enough to treat the patient for a few days, and there is no need for casting. And also, it has less than half sick leave days for the patients. I think these two things, the least we look in our practice, because most of our patients are insured employee, they don't care about absence from work. But if you look at it deeply, it is really very important point to look for in your treatment of the patient. Finally, in 2020, in a meeting, in the effort meeting, in the effort open review, they proposed a guidelines for the treatment of scaphoid acutely. A patient came to you with a picture of scaphoid, history of falling down ostrich hand. You find snuff box tenderness, you find scaphoid tubercle tenderness, pain on the axial compression of the thumb. This strong possibility of scaphoid fracture exists with if you have one or two signs, or any combination of the 1 and 2 and 3 is positive. It is highly indicative of scaphoid fracture. What we do, radiograph of the wrist joint and scaphoid projections, epilateral ulnar deviation and pronated oblique views. If it is normal radiograph, you have the choice to do dorsal wrist cast, and it's better to do MRI within 3 to 5 days, or CT scan. I will add for this CT scan. I mean 3 to 5 days, as soon as possible. It's available immediately, do it. It will diagnose the fracture. Now, if the fracture is detected on the radiograph, you have put short arm cast and do a CT scan. Consider doing CT scan to plan your treatment. As we saw before, that a displacement of the scaphoid fracture sometimes not clear on the plain X-ray, and you need the CT scan to assess the degree of displacement. As we know, it's a big difference between displaced or undisplaced fracture of the scaphoid. Thank you for listening.
السلام عليكم. في البداية بهني زملائي في الخدمات الطبية الملكية على هذا اليوم العلمي المتميز، وأشكر اللجنة العلمية على الدعوة للمشاركة في هذا اللقاء المهم، وإن شاء الله التوفيق. My talk today is about the hope of fractures, and really it lies between missing and arthroscopic treatment. And in my lecture, I'm going to discuss the types of injury, describe the approaches for diagnosis and treatment options, the surgical approach, operative techniques, and we will also talk about what will and what would you do different in other opportunities. So I will start with the presentation of first patient. She is a 20 years old female patient. She was involved in an RTA 11 months ago before presentation to my clinic, and she had at that time of the RTA associated pelvic fractures and abdominal and thoracic injuries. Because of these major injuries, her knee complaint were missed. In spite, she was telling that she had a knee pain, but the X-ray, as she was told by her primary physician, was free. In clinical presentation, she was in good general condition, good soft tissue condition. The knee, there is moderate fusion, and she had a flexion contracture with varus deformity of the knee joint, loss of 30 degrees of hair extension, and she had a full flexion. The stability tests were not performed in the clinic, and the neurovascular examination was okay. Every moment she went to her doctor, a primary physician, she was told that the X-ray is free and she has nothing to be worried about, but the progression of the deformity and loss of function of her lower limb was really annoying for her. Then her doctor tried to think about meniscal problems or soft tissue problems in the knee because she had a locked knee. He ordered an MRI for her knee, and this was the first MRI, and he encountered that there was an injury in her knee, and also he advised her to continue on crutches and non-weight bearing. But she continued to have the complaint, and CT scan was done. The displacement increased. The fracture seems that it healed in this position, and the deformity increasing, and there is also function of her lower limb function. So retrospectively, when we look to this X-ray, the lateral view, the AP more or less it is normal. But on the lateral view, retrospectively, and following the line of fracture on the CT scan, you can find this line of fracture. This is retrospective. This is the normal X-ray. So the lateral view to assess the hope of fractures is not that accurate unless you have a high index of suspicion, and you should add to it an oblique view. So any suspicion of these cases, oblique views for the knee can be useful early stages. But after this late presentation, you will think about something else for this patient. So my plan was to go open technique with median parapatellar approach, and to do an osteotomy to the fracture site, refreshment, more or less the same as this osteotomy for the posterior chamfer for the arterial knee, and mobilization for the posterior condyle fixation. And because in this case it was a medial condyle, and I was worried just only about the PCL if it is entrapped within this fracture, and the lateral aspect you will be worried about the ACL. So this is my approach. Then this is the fracture after opening. I opened a case of total knee, median parapatellar, long approach, and then I introduced my osteotomes or the fracture site, refreshing it in this way and bring it for fixation with 2 screws. And I added 1 screw in order to resist the shearing forces on this posterior condyle fracture. We applied for hair immobilization above knee posterior slab, started in tiptoe touching, and she is started on early range of motion 14 days post-operatively. At 6 months follow-up period, she was having ambulatory without any aids, without any crutches, with no valgus or valgus instability and full weight bearing. After this case, I went through and reviewed my case. What went well? What went well is either because I got a diagnosis for this case, I managed to reduce it, fix it, have a stable fixation for this patient. But for the other cases, I will do early diagnosis with the whole series of X-ray evaluation for any suspected case, for any case that persisted with the pain in the knee with associated injuries. So reviewing the literature about the Hoffa fracture, it was described first by Hoffa in 1904, and it accounts around 8 to 13% of the distal femoral fractures. It is an intra-articular fracture with the coronal plane, posterior aspect of the femoral condyle, high energy trauma events. Often it is missed in the plain X-rays, but easily found in the CT scan, or sometimes if you order MRI earlier. The medial Hoffa fractures, because most of these fractures are due to axial loading on the valgus knee. It involves most of the time the lateral condyle, but the femoral medial femoral condyle is involved less 3 times than the lateral femoral condyle. So I am thinking of that also. It is missed because this injury was on the medial femoral condyle. Here, primary physician didn't think about that. The associated injuries that we should take care, and the message from this lecture is, when we have associated injuries like the patellar dislocations, this is the most common associated injuries with Hoffa fractures, is the patellar dislocation. And most of the time we have these cases in our emergency rooms. So all the patellar dislocation cases should be evaluated carefully for associated Hoffa fracture. Ipsilateral femoral fracture, proximal tibial fracture, especially when they are involving the tibial eminence, patellar fractures as a dashboard injury, and patellar tendon incarceration, supracondylar femoral fractures, varieties of knee dislocations, and also the dashboard injuries without patellar fracture, also associated with Hoffa fracture, and needs a high index of suspicion. Our treatment aims is always to respect the soft tissues, but when you have a neglected case such as my case, the soft tissue here, you cannot do for it much as when you can do it earlier and diagnose it earlier. We should reduce the intra-articular component. We have absolute stability, and we should provide early mobility for this patient. The complications of open techniques, as you know, more knee stiffness, more scar formation, more incidence of infection, and you may devascularize the bone fragments. The period of rehabilitation is extended, and we will have also muscle atrophy that needs long time of rehabilitation and physical therapy. So what I would do different next time is to diagnose this case early, to do all series of X-ray investigations, and to think about using arthroscopic modalities when we have a diagnosis earlier for these Hoffa fractures to fix the minimally displaced fractures or the displaced fractures with arthroscopic assisted technique. Reviewing of the literature, also they said that the incidence of complications and the early return to work and daily life activities is less, and this time needed for physiotherapy, less incidence of infection, and more promising results with a union rate in full union in 29 weeks average. So this is a case also done for a femoral condyle, done with radio, with arthroscopic assisted, and also a C-arm was used intraoperatively, and reduction with a large C-clamp percutaneously before introducing the trocars and the fluid inside the knee joint, pulling out the posterior condyle and fixing it with percutaneous screws. Here also in the literature, when they compared cadaveric studies on the femoral condyle fractures, they found that if you insert the screw from anterior to posterior in the femoral condyle, the resistance for shearing forces is less than when you insert the screw from posterior, from intra-articular to anterior. So, and this is not feasible with the open technique. It is only feasible with the arthroscopic technique. So you put your screw from posterior to anterior and from lateral to medial, it will have the maximum advantage. This is the way of fixing it. This is from anterior to posterior, the screws. And we want to decrease the impingement between the patella and the screw. We countersink these cannulated screws. Then also I started to think about using the Herbert screws in these fractures and the modality that I told you about from posterior to anterior. The other case is a relative of mine. She is 10 years old, female patient. She fell down, slipped in the ground of her house, and brought to the hospital, to the emergency room with this initial X-ray. Really, I saw this X-ray and social event. The patella location is abnormal. It is dislocated laterally, but also here the reduction of this knee joint was hard for the doctor in the emergency room for the dislocated patella, and also the patient continued to have this pain. Here, when we look to the lateral view of the femur, we see a shadow of the posterior condyle and the fracture of the Hoffa fracture on the lateral condyle. And also here in the AP view, you see a double shadow for the lateral femoral condyle. So initial diagnosis was patellar dislocation associated with femoral condyle fracture, Hoffa fracture. And it is a common here. The 50% of the Hoffa fracture are associated with traumatic dislocation of the patella. This is after reduction. Still, we see the double shadow of the Hoffa, and on the lateral view, or more or less, it is oblique view. We also see the displaced fracture of the lateral femoral condyle. And here, I want to emphasize also, to stress in this point, the post-traumatic patellar dislocation. You should also always suspect osteochondral or meniscal injuries associated with it. And also, if you have a difficult closed reduction, or the patient presented to you to the emergency room with persistent dislocated patella, you should suspect further injuries, like this Hoffa fracture. And if it is difficult to reduce it, do not attempt to do it in the emergency room. You will make cause further osteochondral injury, incarceration of the infrapatellar tendon, and even you can do a patellar fracture because the knee joint is not happy with your reduction. So my plan also to do this case, because it is a fresh arthroscopic assisted, And this is the fragment of the fracture. I did for here CT scans and evaluation for other injuries. Then after introducing the scopes with this McDonald or a joystick using K-wire, I will reduce it and then to fix it. This is the initial X-ray after evacuating the hematoma. She presented to the emergency room, then admitted next day. And this is the initial X-ray after evacuating hematoma and irrigation of the joint. The fracture is displaced. الصورة واضحة، ما بعرفش إذا واضحة ولا لا. This is the fragment, and this is the femoral condyle, and here the fibrous material of the fracture. I use the K-wire as a joystick, and I reduce it inside its place, then fixation with a Herbert screw after countersinking from posterior to anterior. And here I couldn't use it from lateral to medial. It was difficult because the meniscus was in my way. So in the mid of the femoral condyle, I put it from posterior to anterior. Here, ما بعرفش الصورة واضحة تبعت الهيربرت سكرو هي هون بالجورا counter synced. This is the initial X-ray, the CR image intraoperatively with a good quality of reduction. Here also, the lateral view intraoperatively, you cannot assess the reduction of your fracture unless you do it with the scope. So the scope is better to evaluate the reduction for your fracture, and also it can help you to find if there is associated injuries. And this is the follow-up. I also splinted here for 2 weeks in the cast and started with early range of motion with hinge knee brace after 2 weeks after removing the stitches. This is the hair X-ray 16 weeks post-operatively, and she is managing well and full weight bearing with more or less full range of motion after the surgery. So the advantages of early diagnosis and arthroscopic treatment is you will have doing your surgery with limited soft tissue dissection, better visualization, and reduction of the articular surface, easy management of any additional intra-articular lesions, for example, meniscus injuries, ACL, or whatever you find. For this case, also we encountered the rupture of the medial retinaculum of the parapatellar tendon. We did percutaneous also repair for it. So you can do the other associated injuries intra-articular with this scope assisted, and you will have a less incidence of complications, I said. My take-home message is this is a coronal plane fracture, can easily missed and can easily be diagnosed early. If you have a high index of suspicion, you should do for it direct reduction, absolute stability. You will achieve interfragmentary compression by the lag screws or the cannulated screws or the Herbert screws. And if you better, especially in the young age, if you can have the absorbable double head screws, it will be the best chance for them, and it is a less invasive technique. Thank you for your attention.
نلزق هاي على هون. يلا يلا زيح. بابا I صرت
على وجه الريجستريز
اولها ريجستريز. سويت نعمل ميوت بالزوم. انا سويت بس مجرد ما حدا يبغى الميوت ترد يفوز. ترى شغال. شوف
السلام عليكم. في البداية حاب أشكر الخدمات الطبية الممثلة بقسم العظام على الدعوة في هذا اليوم العلمي المميز، ونتمنى لهم كل توفيق إن شاء الله. First of all, please, I want you to consider this lecture as an introduction of a new idea, not a lecture or presentation, because we have to think nowadays about registries as a national, to have a national benefit, because we have a lot of medical sectors here in Jordan. We have 4 sectors. We have the Ministry of Health, the Royal Medical Services, the private sector, and the university hospitals. We have, I think, we have to start thinking about registries in order to collect data from all these sectors, to have a number at the national level concerning each orthopedic disorder. We have to start about the introduction. As we all agree that data has been gaining traction as one of the most integral aspects of the modern world, and data is all around us and it's being used to accomplish great things. Currently, one of the best ways to collect healthcare data is with a clinical data registry. The information contained in them can have the benefit in the healthcare field hugely. Points about registries that orthopedic surgeons should know. Number 1, when and where did the clinical data registries started? Some of the first clinical data registries began in Sweden in the 70s in the form of a Swedish knee arthroplasty registry in 1975 and the hip arthroplasty registry in 1979. And then after that, the United Kingdom and Australia followed, founding the joint replacement registries in 2002 and 1999, respectively. Second point, what is a clinical data registry? It's a clinical data registry. It's a record for information about the health status of patients and the health care they receive over varying periods of time. They are designed to capture clinical data of importance to healthcare practitioners, providers, and patients. Generally, registries focus on clinical data for specific populations based on a disease condition, procedure, or medical device or drug. Who can manage registries? Many different organizations and societies have created and managed registries. These organizations include the medical specialty societies and the medical council, patient advocacy organizations, and governmental organizations. Who is interested in the registries and who can they benefit? There are groups of people that can benefit from data housed within the registries. The way they use it differ, but their ultimate goal of improving patient care remains the same. These groups are the hospitals, healthcare systems, private practice groups, physicians, health plans, and other payers, patients, researchers, device management companies, and patient and consumer organizations and government. How do registries collect data? There are 2 main methods of data collection that registries utilize. One way is the data that can be pulled out from the electronic software records, and the other method is from the patient himself. Registry should be very careful with the protected health information and follow several steps to safeguard patient as well as surgeon privacy. Why do you think the registries are important? First of all, quality improvement. Registries can be used for quality improvement initiatives by comparing figures at participating institutions over a period of time. Trends can be noticed and areas that should be focused on, like surgeon experience, type of prosthesis, approach, etc. I'm talking mainly here for the registries for arthroplasty. That's why I'm talking about type of prosthesis and approach. Other benefit, sharing the experience between the healthcare providers and the healthcare sectors. benchmarking يعني بالعربي المرجعية، لازم يكون لنا مرجعية إحنا في أي أرقام عنا يكون لها مرجعية للهيلث كير، للبروتوكولز، للبري أوب بوست أوب، للتايب أوف prosthesis. If we have the number, if we have the information, we will have the success. The most important benefit of the registry is the research. Research is the most valuable way that registries can be used. Registry research can lead to medical discoveries and reveal successful surgical techniques. هلا زي ما لاحظنا قبل شوي انه كلهم عم بيحكوا عن الامريكان اكاديمي وريكومنديشن فروم effort فروم بلا بلا بلا. هلا هذا كله شيء كويس، بس احنا at the national level we don't have any recommendation. For each hospital or each sector has its own recommendation, but at the national level we don't have numbers. We don't have any recommendation. For example, the importance of registries. The Norwegian Arthroplasty Register detected poor performance of bone lock, which is a type of bone cement, by showing a download slope in the survival curves of well-known implants that have been already consistently providing satisfactory outcomes. يعني بعد ما سجلوا لاحظوا through the data extracted from registries إنه هذا type of bone cement is not functioning well. بعد هيك سحبوه من السوق. The most striking finding from the Norwegian Joint Replacement Registry is that all total hip arthroplasty and total knee arthroplasty innovations introduced between the year 2003 and 2007 failed, although they had obtained marketing licenses via procedures similar to those used in Europe, proving that these procedures are inadequate. يعني الموضوع مش موضوع فقط licensed FDA approval or Jordanian FDA approval. We have to have our own data. We have to have our own information based on statistics. Other benefit of registries, cost-saving effects. For example, in Sweden in 2002, the cost for total hip arthroplasty revision was estimated to be about $11,700 US. After decreasing 1% in the number of revisions based on the better experience, based on the information extracted from registries, this would save about $1,368,000 US. The Australian National Joint Replacement Registry showed revision rate decrease from 14.8% to 11.1% for total hip arthroplasty, from 10% to 7% almost for total knee arthroplasty over a period of 4 years. This will correspond to a cost decrease about 4.4 million Australian dollars. As well as in the USA, 5% decrease in the revision rates would save about 30 million US dollar per year. So the information extracted from the registry can be useful for the financial purposes, for the cost effectiveness of each procedure that can be done in the country. What are other examples of national registries? American registries expand over countless specialties and fields. Some of the most prominent are the American Joint Replacement Registry and the Intelligent Research Insight Registry and National Cardiovascular Data Registry. Groups like National Quality Registry Network created by the American Medical Association. It is a voluntary network interested in advancing and development and use of registries to evaluate and improve patient outcomes. The American Medical Association leads evaluations of registries on behalf of the National Quality Registry Network regarding the operations and sustainability of existing registry and other useful projects. What about our society? The future of registries will depend on willingness of health authorities and healthcare professionals to support the creation and maintenance of these tools, and the coordination between all national health systems, and huge support of surgeons and the cooperation between our society and the medical companies. This slide for the future of registries. Conclusion. The creation of registries of implantable medical device ensures the effective post-marketing surveillance and allows the detection of defects before they translate into public health disasters. Well-designed registries that receive proper input from healthcare professionals are among the most powerful marketing surveillance methods available to date, and registries are a main manifestation of the evaluation culture. Thus, their widespread development in some countries and their virtual absence in others highlights the impact of cultural differences on healthcare evaluation. At the individual level, registry will allow each surgeon to compare his or her practice to that of the overall community of surgeons with the same specialty. At the national level, registries will provide unique information on the performance of implants and healthcare institutions, and this maturity of the actors involved is a key factor for the development of registry aimed at achieving overall improvements. Does anybody have an answer about the number of yearly total hip replacement in Jordan, total knee replacement in Jordan, revision per year, causes of revision, performance of different prostheses, patient satisfaction, financial burden? I'm pretty sure no one of us will have the exact answer. Thank you.
The next lecture is going to be hemodynamic
Thank you, Dr. Kam. It's an honor to have you between us today. I will further introduce Professor Axel Gansler from Germany. He's a well-known reference in pelvic ring injuries with many publications, the last being 2 months ago. And it's an honor to have him between us as a guest speaker today, international guest speaker. He also happens to be one of my teachers and instructors. I learned a lot from him. Professor Axel?
Yeah, salam alaikum, everybody. Good morning. You have to activate my monitor because I'm not able to come on my monitor. So I try that it's going. Can you see everything?
Not yet, sir, but sharing is online for participants now.
Can you see the slides?
No. Not yet, sir. No.
Okay, now it seems to be that it's possible.
Now it's activated.
You can see it now?
Yes.
Okay. So again, good morning, everybody. I will talk about the hemodynamic unstable patient with a pelvic ring fracture, and pelvic bleeding comes from the cancellous bone, the veins, which consists of the retroperitoneal veins and the plexus, and in some cases from the arteries. We have to respect the anatomy. And it's interesting, if you look to that picture here, you see that the veins are much closer to the bone than the arteries. And we all know that the veins have a smaller wall. And therefore, there's a higher risk that we have a venous injury. And this was stated several years ago, that fatal venous bleeding is expected more frequent than acknowledged up to that time. This is a discussion we took over recent years when we are talking about pelvic packing and angiography. And therefore, arterial bleeding is often overestimated. Marvin Teil already stated that the pelvic fracture bleeds to death, whereas the acetabular fracture limps to death. So we are in a fight against the time and, of course, in a fight against the patient in extremis. And you see some of the definitions about the patient in extremis. There is no uniform definition. So it's a low hemoglobin, reduced systolic blood pressure, despite catecholamines or even packed red blood cells. And we have some European landmark papers from the last decade, which focus on pelvic stabilization and hemorrhage control. So the first thing to do in these patient groups is perform any pelvic stabilization followed by hemorrhage control. So the treatment concept is first mechanical stabilization, second surgical bleeding control in patients in extremis, which consists of indirect techniques. We propose clearly the extraperitonal pelvic packing and tamponade. I will discuss that later. We have to consider reboa, and we have to consider as well angiography and embolization. Beside the indirect techniques, of course, we are surgeons. We have to think about direct open surgical bleeding control because it's necessary in some of the patients. And beside everything, we have to treat the trauma-induced coagulopathy. So the first thing is to mechanically stabilize the pelvis. So somehow fix the pelvis. This is the main message. You have to fix the pelvis with any possible helpful tool. So the plan A for us is the pelvic binder, the pelvic sling, or even a simple towel as shown here in these pictures or in these pictures. Of course, we usually use the pelvic binder. It's most easy and a very, very simple procedure. Normally, you perform this procedure within 11 minutes after admission of the patient, and we know clearly from the literature that it reduces mortality even in severe shock, and we have some kind of bleeding control from fracture compression. And of course, it doesn't cost so much. The historical standard stabilization measures are the external fixation, either anterior or posterior. The anterior external fixator use a simple one. It's only necessary to put 2 pins on each side. This gives you some kind of stability. Every addition of other pins increases the procedure. But it does not stop arterial bleeding. It's optimal only for type B open book injuries. This was the reason why the pelvic C-clamp was developed. It was already published in 1964. But you need some special surgical skills. It does not stop arterial bleeding, and it's optimal for type C pelvic ring fractures. My personal plan C is if you don't have these measures available in special situation, or you come in a situation where the patient deteriorates, we perform a damage control stabilization with either a wire or even a screw. You only need a carbon table, and you have to know the pelvic anatomy and need a good anatomic understanding. We only use the AP view of the pelvis. Here's another example where we put in a screw posterior to the sacrum, like a standard Harrington sacral bar. And the main message is it's always better to fix the pelvis than to leave it unstable, because this procedure saves lives. So for the mechanical stabilization, always first mechanically stabilize the pelvis. Do it immediately because it prevents further blood loss, and your time window to do that should be within the first 10 to 20 minutes after admission of the patient. You see here an example where we put in a towel around the pelvis. This was a traumatic hemipelvectomy, which was followed by the C-clamp. Today, the C-clamp is relatively cost extensive, so not every hospital is using a C-clamp. The second part is surgical bleeding control. And we know these patients who are dying within the early minutes after admission. And our plan A is pelvic packing, which is an extraperitoneal approach. And it's a very, very simple procedure. You see the steps. We make a vertical midline incision. We identify the midline of the linea alba between the rectus sheaths. Then after incising that, you see the rectus muscle bellies, and then you only have to open the posterior part of the fascia, and you can see that there is a tremendous amount of blood in the pelvis in special patients. And then we pack everything. We put it on some towels to both sides. This is important because usually the fascia are already disrupted on the affected side, but with ongoing time, you will have some bleeding to the opposite side, and therefore it's necessary to perform the packing on both sides. And again, an anatomic view where you can see that you can address all these veins which are close to the bone in these patients. A clinical example for that. So pelvic packing is early performed. Usually we are able, from our analysis of our patients, within 70 minutes after admission, but we have still a mortality rate of more than 50%. This means it is a highly unstable patient group, and we expect a blood loss of 1 to 2 liters per hour, which corresponds to the ATLS group 3 to 4. These are real patient in extremis, so you don't have time. The plan B is, if packing fails, if you have it, if it's available, consider rebore, because it's a simple approach to a vessel in the groin area, and you can put your balloon to the lower aorta to block the aortic arterial inflow to the pelvis, and you even address the venous bleeding as well. But it's only a temporary measure. For stabilization should be followed as early as possible by definitive surgical bleeding control. And we have 3 zones. The zone 1 is that you put your balloon up to the proximal aorta, and there you have to leave it because you involve blood supply to the abdominal organs less than 45 minutes. In the zone 3, which is below the level of the renal arteries, you have a little bit longer time for that. So it is an option to do that immediately, but it has to be available. And to reduce the time window for definitive surgical bleeding control, this is a clear damage control procedure, and you have to perform it already in the emergency situation. So the question is, if both fail, what to do within our classical window of 3 hours intervention? We propose a repacking because normally at the initial time, you cannot see any veins, any arteries. You only have to pack because there's a tremendous amount of blood coming from the true pelvis into your surgical field. And probably when now 70 to 90 minutes are away after admission of the patient, you have a better view to the pelvic area, and we perform a correcting of the towels integrated into the pelvis to get a better overview. And this led in many cases to a more and adequate bleeding control. The plan C is, let's talk about what we are. We are surgeons, and surgeons are responsible for surgical procedures. So think of a damage control approach to the veins and arteries as well. So we should be able to perform such an approach, such a surgical approach to the femoral artery, to the external vessels and the internal iliac vessels. And you can see it here. This is a classical approach to the femoral artery. It's a relatively easy approach. We know where the artery is, and in this situation, you only have to incise the soft tissues, and then you are more or less directly at the artery. And even every surgeon should be able to block that artery if there is a lesion. It's a little bit more complicated if you go to the internal or external iliac arteries. To get access to that, you need a good knowledge of the anatomy and be sure that in these situations of a dying patient, the anatomy is not so optimal visualized than with this view. So what you have to know, if you want to go to the external iliac vessel, you perform a modified ilioinguinal approach. So the classical ilioinguinal approach is running from the aces to the pubic tubercle. So be a little bit more proximal to that. Then you have direct access to the vessels and can block the external iliac vessels. So you are familiar with that approach if you are pelvic surgeons. If you have to go to the internal iliac vessels, you use the pararectus approach. It's shown here, the typical incision, it's close to that area, but you address a little bit more to the medial side compared to the other incision, which is running in that area. And then you have access to the internal iliac vein and artery, and even to the lumbosacral trunk. So you can use this approach as well for decompression of the lumbosacral trunk. And last but not least, if you have two parts of a vessel, it's relatively easy to put a shunt in. So it's only necessary to put it in and make a suture until the vascular surgeon is available in these situations. The plan D, the fourth thing, is the angioembolization, which is optimal for arterial bleeding. It's well established and successful, but the rate of re-angiographies is between 2 and 25% after the first day. So it is not optimal for the most common venous injury. But consider if you have ongoing bleeding, if you have ongoing hemodynamic instability of the patient within the first 2 to 3 hours, you have to think about to perform the angiography. But you need someone who is able to do that. And we know that the time window is extremely essential to do that because it influences mortality. This is a very old study which already showed that if you are within 3 hours to perform the angioembolization, the mortality is 14%, but increases to 75% if you have a delay to perform that embolization after 3 hours. Interestingly, even today, if we look to the literature, and this is a sum up from the literature from the last years, we have a treatment delay to perform the angiography, even in larger hospitals, with an average time window of 3.5 hours. So we start already with a negative effect for the patient. For a long time, for the last 2 decades, there was an ongoing discussion about pelvic packing and angiography. And if we look in detail to the presented literature, we see that pelvic packing is performed earlier. You see the numbers, the minutes. It's performed in patients who are or who have a higher injury severity score. We know that it decreases the blood transfusion rate over the first day and is associated with lower mortality. So last but not least, we don't have to discuss these patient groups because they are completely different. And we know that angiography takes time. And we usually cannot perform any other treatment simultaneously because we are in the radiology department. And of course, you need the skilled interventional radiologist, which is sometimes a problem in many hospitals because he is not available for 24 hours, 7 days, only in few hospitals. And again, only 14% are performed within 90 minutes. This should be our time window. And there's one study which is really interesting. During transportation of the unstable patient to the angio suite, they observed 20% cardiopulmonary resuscitation. Last but not least, it's necessary to think about coagulopathy because coagulopathy influences mortality and is increased. The rate of coagulopathy is increased with higher injury severity scores. So we have to think about ROTEM analysis of this patient group. It should be available as one of the options by the anesthesiologist during the resuscitation of these patients. And we know that coagulopathy is an independent risk factor of mortality. And we know as well, and this is based on these scientific analysis with ROTEM analysis and so on, that a low transfusion versus fresh frozen plasma rate reduces mortality, especially in the first 6 hours after admission. And the overall transfusion requirements are additionally reduced. So in conclusion, it's necessary if you want to deal with these patient groups to understand the pelvic anatomy. Somehow fix the pelvis. This is the first thing you have to do. It's the most important thing. Consider your time when you performed your driving license. We learned from first aid examination that we perform a pressure on any bleeding, and the pressure is only working if we have somehow stability of that region. So fix the pelvis first and then control the pelvic bleeding. In patients in extremis, we clearly recommend direct extraperitoneal pelvic packing. It's a simple procedure which should be possible for every surgeon because it's the same approach as going to the pubic symphysis. Think of rebore, think of vascular surgery and angioembolization as a plan B to D. And of course, during the whole procedures, you have to consider the coagulopathy because more than 40% of these patients are already in a coagulopathic status when they arrive in the hospital. Thank you for your attention.
Thank you again, Mr. Moderator, Dr. Kamel. Big thanks to Professor Axel for this great talk. Professor Arnold Suda is the head of Salzburg Trauma Hospital in Austria, and we were privileged to have him here in Jordan through the previous Jordanian Royal Medical Services conferences, and I guess as a guest surgeon, we did together over like probably 17 or 18 cases of trauma and orthopedics, complicated cases, especially in septic orthopedic surgery and reconstruction. Professor Arnold, it's good to have you with us. Please proceed. Thank you.
Dear Guy, very nice to see you again, and I'm very glad to be here and part of the conference. Thank you very much for this. Dr. Guy, thank you for the invitation. I'm very happy. But I just see that Axel, you're still online. If you stop sharing, then I can share.
Axel, if you can stop sharing, please.
It's not working at the moment for me, so sorry about that.
Now
it's possible.
Thank you. Danke dir. Servus.
Sorry, Arnold.
Yeah, ciao. So now I can share with you. I hope you can see my slides. And I will start with the okay. It's okay?
Yeah, it's okay.
Okay. So I will talk about the current treatment concepts of infected bone non-unions. And of course, you all know these images, these pictures, but you still have to keep in mind that it's not to blame the osteoblasts. Basically, bone is going to heal without any surgeon, which is very surprising for us, but it's a fact. And we have many factors who are harming the union of bone. So our plan or our achievement has to be to support the nature and not to stand in the way of the nature. So vascularity, stability, and infection. This is the biggest problems of non-union. You know these pictures of open fractures, high impact trauma, and late first treatment. These are risk factors for developing non-healing bone. Even the muscle trauma, the whole soft tissue problem is one of the main issues in non-union of bones. So you know all these risk factors. Maybe the Jack Daniels is in Jordan not #1, but smoking, of course, is harming the bone union. Next, diabetes and rheumatoid arthritis and chronic infection diseases. Malnutrition and even obesity are very important risk factors as well. So the surgeon is another risk factor, because the surgeon decides about approach, the choice of the implant, and especially the soft tissue management. And this is very, very crucial, because the timing of the surgery in combination with the approach and the implant will be crucial for achieving union or not. So the timing, you have the choice about the early treatment in open fractures, or early but late treatment in closed fractures. And of course, you have to look about the compartment syndrome. You have different techniques, minimal invasive techniques, and overall, the important thing is a smooth soft tissue handling. You should be fast, but not hurrying, but a fast technique, which means you need experience to approach it, because as fast as you are, the less risk factors you will have. The antibiotic prophylaxis is mandatory. There is 20 years ago, 30 years ago, there was a big study which is obvious that ceftriaxone or other antibiotic is working and reducing infections significantly. This infection causes the union because the bone will be devascularized, and then there will be a fragmentation and a dissolution of the fracture hematoma. And this is causing the non-union. So if we go from the osteomyelitis, what's happening? It goes over thrombosis of the small vessels to sclerosis and dead bone to a sequestrum, and from this to osteolysis, and then to the non-union. There are a lot of classifications. Maybe you know the Czerny-Maeder classification or the AOOTA classification. These are classifications widely used, but keep in mind there are a lot of classifications of infected non-union. Some of them are only clinical, some of them are only radiological. But this classification used by the AO is I think, quite good, approaching the bone loss and the bone quality. How to diagnose? Of course, it's pain. Of course, it's swelling and the sinus and infected hematoma. And it's an irregularity in bone imaging. Even the blood cell count, you have elevated leukocytes, you have elevated sedimentation rate, and you have your CRP. But can you be sure that it's really infected? You have imaging. You can use X-rays. It's quite non-specific because you can face non-union without any infection. You have MRI, which is very sensitive and specific, but still, can you be sure that this is an infected non-union? You can use nuclear medicine, and you have several tools to diagnose. But if you have a negative scintigraphy, and you have a negative leukocyte scintigraphy, and you have a negative antigranulocyte scintigraphy, which are three very expensive and let's say difficult to get diagnostic tools, then you will have no infection. But if you have a positive scintigraphy and a negative leukocyte and antigranulocyte scintigraphy, what does this mean? Nothing. Does mean nothing. Because only if you have a positive leukocyte scintigraphy, you can be sure you have an infection. And if you have everything positive, maybe there is infection. So please, you have to look wisely, to choose wisely what kind of nuclear medicine tool you choose. Personally, me, I don't use scintigraphy at all, because I don't get the information I need. If we look at the bacteria in bone infections, we face Staphylococcus aureus most of the cases and the gram-positive ones. And of course, we have mixed bacteria in the bone. It will be the same in Jordan as well. And our goal is primarily eradicate the infection. This is the most important goal. After this, we need to achieve the union. And after this, we solve the soft tissue problems. To eradicate the infection, You have, of course, to increase the host resistance, including the antibiotic therapy, and then somehow decrease infection load. And how can you do this? With irrigation and debridement. This is the most important thing, to ream the infected bone, to bring everything out, to do resection and not just do minimal scratching on the bone. No, do resection and remove all the suspected bone until you have bloody bone. And in acute infection, don't wait for the biogram. You have empiric antibiotic therapy, so please start it. And if you have the antibiogram, you can change it, but do not delay antibiotic treatment in these cases. How to get the biogram? Take tissue samples and no swabs. This is mandatory because in the swabs, you have a lot of false negative diagnosis. How long to give the antibiotics? Nobody knows. Nobody knows. Between 2 weeks and 6 months, everything can be possible and can be smart. There is no common sense about that. But keep in mind, you have reserve antibiotic. You should not use vancomycin in every case. And in MRSE, you have to combine the antibiotics. Choose wisely. Maybe you can go to antibiotic treatment without creating more and more resistances. The implant-related problem is crucial because methylene infection, as you know, are poor partners, and you have a lot of biofilm building and bacteria, and this is what it's all about. The local antibiotics, they are working very well. I use them myself a lot, but to be honest, there is no evidence for this. There is no study showing that local antibiotic is better than doing just irrigation and debridement. You have to do, as I said, radical debridement. The image on the left side, this is not debridement enough. You have to do completely debridement until all the infected things are removed, even if you finish in a position like this. Dead bone stays dead bone. You see this bone, this white shining bone without any bleeding. This is dead bone. So you cannot do a kind of reanimation here. You just have to remove this bone because it's dead. So to achieve the union, we have to activate the body. We have to activate the cells, and we have external stimuli like ultrasound therapy or some electromagnetic therapy. But to be honest, if we remove the dead bone, allograft or even autograft are the best techniques we have. You all know the technique after Masquelet, and there are, of course, alloplastic things like ceramic or glass or the bone transport. The third goal is solving the tissue problem. There, in these cases, we have to do flaps, faciocutaneous flaps, muscle flaps, or even free flaps, because to bring a blood supply to this healing site, then the healing will be achieved. And you can correct the deformity using an X-fix like Elizarov, for example. A crucial technique is the Osteoperosial Decortication. You have to open the bone to bring the healing and the nutrition into the healing site. These pictures describe how this decortication is performed. You have to go into the core of the bone, and then you can do the allograft on this site. What to use in autologous cancellous bone graft? You can use this for osteogenic, osteoinductive, and osteoconductive matter, and this is very smart. There are different techniques to take the autologous cancellous bone graft from the pelvis, inner side or outer side, with different approaches possible. But is there any evidence for bone graft substitutes? To be short, no, not really. Maybe you know the ActiFuse, or you know the Alpha BSM, or maybe you know the Vitos or Cortos. And to be honest, there are only 1 to 4 level 1 studies to show that there is somehow any evidence for these for these bone substitutes. Of course, it's working. I do it myself. But if you ask about, is it evidence-based to use it? It's not really evidence-based. Even with another, the Norian calcium phosphate, there are, of course, level 1 studies, but very few. So the mechanical stabilization seems to be crucial in these cases. You can plate them. You can use wave plates. So you put the bone graft under the plate and you reconstruct the bone on the other side. You can do intramedullary nailing. You overream. You use the thickest nail you will get. You can do resection with a fibular, vascularized fibula graft, for example. You can do an X-fix with a bone graft in the tibia bone loss, for example. You can do bone transplants, as I told you. Or what you can do is you can do callus distraction, as described by Elizarov. This bone transport is very smart because it's the bone of the patient. It's no graft. And of course, there are some limitations. But basically, if you have the right technique, it's a very nice method to leave the patient with his own bone. You do this osteotomy and you start with the distraction after some days. And you need to do the osteotomy on the right side and not to cut the bone, to only cut the cortex and to leave the core of the bone. This is very crucial. You can use ring fixators, unilateral fixators, and you have some advantages and disadvantages. Of course, the pin track infection and the soft tissue problems and the low comfort and the long treatment time is a problem in the X-fixes. You can use a monorail, even over a nail. And there are as well disadvantages and advantages, especially you have a central docking as a big advantage. And you can combine an X-fix with a plate. This is a very smart thing because you can remove the X-fix after your distance of transport is achieved, but you cannot transport faster than 1 millimeter a day. This is very well published. So you need a consolidation phase between 3 and 5 days per millimeter. So overall, in a 6 centi defect, you need overall more than 300 days of treatment until you will achieve union. It's a long time, but you achieve union with the patient's bone. The docking site is crucial. Maybe you need bone grafting or plates in these cases, and you have a lot of complications regarding the pin tracks. The regenerating bone has the problem of the consolidation if you have a smoker. And I will show you a case of a guy with this open healed fracture, as you can see here, with a flexion of about 40 degrees. This is the CT scan. And first there was the resection with the spacer. Then there was a monorail X-fix with a plate and a flap. And then there was the transport done. And as you can see here, after a time, after the transport, the X-fix was removed. And after a time, it healed, and you can see the regenerate and full weight bearing was possible. And this was the clinical aspect, and the guy is walking again. So to conclude, in the treatment of infected non-unions, this all remains very complicated, and you need the specialists to do it. So maybe everything should be done in centers for bone infection or even in departments for bone infection. You have many different approaches, and you should always be aware of the surgical principles, and you should always consider different approaches and individual approaches to the patients. And I think even in these complex cases, there is no time for experiments. You should have specialists in centers to do this. Thank you very much.
Thank you very much for this.
Prof. Suda, thank you very much for this very nice, concise, direct presentation. We concluded our lectures for this session and we have time for questions. We'll start with your lecture. So you will be free after a few minutes. We know it is Saturday and we are grateful for you that you share your ideas with us. And any questions? أسئلة regarding bone non-unions or pelvic fractures. في حدا عنده سؤال؟ لسه بعد هالدين. I have a question. I noticed one of your, actually two questions. One regarding the bone scintigraphy. I'm clearly with you. I don't use them at all. They are not helpful. And frequently, I got periprosthetic infections. Are they helpful in that context, or is it like in fracture treatment, not helpful at all? What do you think?
It's a very good question, because in many, many cases, if I get the patients referred to my department, for example, they already have a scintigraphy in periprosthetic infections. And to divide a patient with a wear in the scintigraphy and an infection is almost impossible. So in my opinion, there is no need for this. But many doctors, they do it. I don't know why, but they do it.
So can I take a clear message from you that bone scintigraphy is not helpful in fracture infections or periprosthetic infections?
This is correct. If you use MRI, it's not helpful, yes.
Thank you. My second question is regarding rifampicin and vancomycin. Now we know that vancomycin is a very precious antibiotic, and we should not start with using it unless we have a peer culture or a consult with the ID people. I noticed that you, in one of your slides, you said never alone. Is that for vancomycin or for rifampicin? Can you comment on that?
Yes, it's for vancomycin, because vancomycin is, as you said, very potential antibiotic, and but needs some second substance to penetrate in the bone and soft tissue. So the best combination would be, for example, if possible, and the antibiogram will give you this hint, to combine it with, for example, clindamycin or rifampin, everything, something like this. So then you double or triple the strength of the vancomycin in the tissue. And if you take tissue samples and check the level of this antibiotic, you will realize that this is very potential in combination alone. But if you take it just vancomycin, you have the chance to generate these resistances we don't want to face.
Yeah, thank you. And rifampicin as well, we know it's very sensitive for resistance. So if you use it, the bacteria will develop resistance in a few weeks. So rifampicin never alone. Vancomycin, this is new for me. If I have a culture and I'm pretty sure it is MRSA and it is only sensitive for vancomycin, we might use it alone. But this is something new for me. Thank you. Dr. Walid, we have a question here. الميكروفون والله. ممكن. Question from Dr. Walid Haddad, who's a hand surgeon and doing some trauma.
My question regarding the diagnosis, if you say that scintigraphy is not beneficial and the presence of metal, either plate or nail or a prosthesis, the MRI will give a lot of artifacts. And what we are left with to diagnose an infection, is it a septic non-union or septic non-union? Which one, how to diagnose it? Thank you.
Clinically and surgically, I look at the patient, and even I go into the patient and I take a biopsy just to be sure, because it's much more sensitive and specific than imaging in these cases.
So you go for two stage, first for diagnosis and then for definitive surgery.
This is correct.
Yeah. Any more questions? Dr. Ghaith has a question.
Hello, Arnold again. So this question is for Axel. For Axel, I have another question for Arnold actually. So Axel, in Germany, as a general standard, we did not hear much about the C-clamp. Is it still in use in the emergency departments, or is it, as you said, stabilize the pelvis, then go for packing, and then angiography or angioplasty performing the vascular ballooning? So are we still using the C-clamp in the emergency departments in Germany?
I think that there are many hospitals which still has the C-clamp, but the level 2 hospitals usually don't need the C-clamp, because the cases we have in level 2 hospitals are 1 or 2 cases every 2 years which need the C-clamp. So the hospital director clearly states it's too expensive and it's not necessary. Last but not least, it is from the official standpoint, it's a good idea to have a posterior stabilization, but the pelvic binder is as useful as the C-clamp. It is much more cheap compared to the C-clamp. So there's a clear trend at the moment not to use the C-clamp any longer. So the pelvic binder is usually already applied at the scene, and the patient arrives in the hospital with the binder. And the only problem is that we have problems of identifying high unstable injuries, because the binder reduces the pelvis in an extremely good position. And it's sometimes very difficult to clearly see where is the instability. We have the feeling that it's a minor injury, but when we open the binder, the patient becomes very unstable. So we have to talk to the anesthesiologist before we open the binder. And there are some algorithms available which guide you when to open and how to open the binder. Of course, you have to consider the soft tissues, not to leave the binder for 24 or 48 hours.
Thank you.
Arnold, would you comment?
Yes, I just want to ask you a question, because do you use dual energy CT scans for the pelvis after you use the binder? Because in these cases, you can see these instabilities like in osteoporotic fractures a little better than in a normal trauma scan CT.
Not as a standard, and the reason is that not every hospital has a dual standard CT scan. So we use the standard CT with every radiological support to detect arterial flush, something like that, to get an idea if there's any injury. But of course, you will see that in many cases without having any hemodynamic instability. So last but not least, it's a clinical decision. And we have very often patients who arrive in the hospital, and if you ask the emergency physician what happened, the patient tells you what happened. So you can be sure that it's not an extreme injury. We are talking about a really dying patient where you have 5 to 10 minutes to deal with that.
Thank you. Any more questions? Here we have a question for Professor Souda.
Arnold, regarding the latest or most recent studies on infection control, hospital-related factors or doctor-related factors, there was a lot of talk about the laminar flow and or the number of door openings and all that, the number of stuff. So what's the most important factor you would put as number one in infection control, out of all these factors?
You have two really evidence-based factors for infection rates. One is the number of door openings, as you said, and the second is the number of people in the OR. This is the only two things. It's not the laminar flow, and it's of course the duration of the surgery, but these are the two most important things. So we feel that there are a lot of more things influencing the infection rate, but we cannot prove at the moment. It's only these two things. You know what we do in our theater if we do, for example, arthroplasty or revision arthroplasty? We block the doors from outside. So only people can only go outside, but cannot come inside without that anyone in the room allows it.
But reality shows that the anesthesiologists change the teams during the surgery.
3 times. Yeah.
So at the end of this session, I would like to thank all the speakers, national and international. Special thanks to Axel Gansland from Germany, a well-known reference in pelvic injuries, trauma, and with many publications, and an AO instructor. Again, Arnold Suda from Austria. Thanks again for joining us, and you have great contributions to orthopedics to your publications and studies also. It's a great honor to have you here. Thank you very much.
Thank you very much. Thank you all. It's a great pleasure to have you. هلا احنا هنا بدنا نعمل شغلتين. الاولى في تكريم للدكتور زياد العودات، اجى متاخر، فجزء من التكريم قدم الدرع للدكتور زياد العودات. فدكتور زياد استاذ دكتور في مستشفى الملك عبد الله والدكتور بيعرف مجهودات كبيره. شكرا جزيلا. وإذا في أسئلة عن المحاضرات الأولى، يعني على الأقل أو على الأكثر كل محاضرة سؤال. في حدا عنده سؤال عن المحاضرات الأولى؟ تفضل دكتور هناك. تفضل دكتور. نعم. هو دكتور كثير بتعتمد على الجراح وخبرة الجراح والافيلابيلتي اوف انسترومنتس والادوات. هلا في كثير من هدول المرضى بيجوا بالويك اند. هلا بالعالم الغربي هدول المرضى حتى انه يشتغلهم بده يشتغلهم ارثروبلاستي سيرجن، وبتعرف التروما بيشتغلها الجنرال اورثوبيديك سيرجن. فحتى تحطوا ستاندرد انك انت تعمل توتال هيب ريبليسمنت بدك تصير تجيب الارثروبلاستي سيرجن يوم الجمعه والسبت انه يعمل. اذا بتطلع على الليتريتشر كثير ستاديز حتى من شمال اوروبا اللي هم بيعملوا يعني كل شيء لما بيعملوا راندومايزد ترايل انه مين احسن توتال هيب ريبليسمنت ولا بارشال هيب ريبليسمنت، بتلاقيهم عملوا راندومايزيشن اللي بنعمله خلال اسبوع بحطوا لهم توتال هيب لانه بيشتغلها الارثروبلاستي سيرجن اللي مداوم، واللي على الويك اند بيعملوها اللي هو اي حدا مناوب في هذاك اليوم بيعملوا الهيم ارثروبلاستي. هلا هي ثابته من ناحيه فانكشن للمريض التوتال هيب قد تكون احسن قليلا من البارشال هيب، لكن الكومبليكيشن ريت والسكند سيرجري اعلى. فهي احنا الاستدي تبعتنا الاقل من 65 اكسكلودد. هلا اذا بدنا نعمل توتال هيب للاقل من 65 للفانكشنالي اكتف حسب الاخصائي المناوب كمان، لانه يعني مثلا في عندنا سباينال سيرجن بغطي الجنرال تروما. احنا بجوز فرصتكم بالخدمات الطبيه تكون افضل لانه صار في عندكم تروما تيم. صحيح انه التوتال هيبس بنعمله بالملكه عليا، لكن ممكن انه يصير حدا متخصص يعملهم مع التروما تيم لانه في عدد حالات اكبر. هي لحد الان هي جادجمنت على الفانكشن والدياجنوسز. يعني اذا المريض عنده دامجد اسيتابيولم او عنده هيب بين قبل، يعني مثلا كان انكيلوزنج سبونديلايتس وصار عنده فراكشر، لهم هذول الحالات القليله. او انه يونج بيشنتس، احنا عندنا كثير يونج بيشنتس بصير عندهم فيمورنيك فراكشرز، عندنا اوستيوبوروتيك بون، بس هذول غالبا بيكونوا تحت ال 65. ما بعرف جاوبتك انا ولا لا. تفضل دكتور.
they respond in the as in general patients, we noticed that the pain they don't go macro. They need time to get out in pain or
دكتور بدك رأيي ولا والله شوف يعني اذا بتحط لهم سمنت التوتال هيب ريبليسمنت يعني they do very well. الصغار بالعمر اذا بتحط لهم توتال هيب وبتمشي الامور بدون كومبليكيشن بتمشي الامور من احسن ما يكون، اكيد احسن من الهيمي. هلا مقارنه مع المرضى تبعين التوتال هيب ريبليسمنت هي المين كونسيرن شغلتين، الديسلوكيشن لانه عندهم فيري جود رينج اوف موشن قبل العمليه، والشغله الثانيه الانفكشن لانه انت بتعملها اون ايرجنت بيسز وما بتكونش محضرهم ومضطر انك انت تعملهم، يعني ممكن يكونوا الهيموجلوبين A1C عالي، ممكن يكون سموكر، ممكن بس الفانكشن ديفينتلي بالتوتال هيب باليونج اكتيف بيشنتس احسن من الهيمي ارثروبلاستي كفانكشن، كل العالم بيحكي هيك. لكن الكومبليكيشن يعني انت بتحسبها هلا انت يعني هذول الهيب فراكتشرز هذول رينج اوف بيشنتس، في مرضى والله يعني الاوستن بكفيهم، يعني عارف كيف بيجيك واحد عمره 85 سنه اولموست بيد ريدن وعنده باركنسون ورينال امبيرمنت، هذا تبدا تعمل مغامرات تعمل له توتال هيب ريبليسمنت يعني جنون. وبيجيك واحد بيكون هيفي سموكر ولكنه فانكشنال بروح وبيجي وعمره 65 سنه وفيري اكتف فيري اكتف وبيشتغل وبروح وبداوم وبيجي، هذا بتحط له توتال هيب وانت مرتاح. يعني هاي انطباعات. الليترشر واضح، الفانكشن توتال هيب، الكومبليكيشنز الهيمي، يعني اذا بدك تحسبها هيك احسبها هيك. طيب بقيه المحاضرات محاضره الدكتور هاشم هوفا فراكتشرز، في حدا عنده سؤال؟ انا بحياتي شفت 4 هوفا فراكتشرز، واحد كان بنفس الشخص بايلاترال، كلهم باللاترال فيمورال كوندايل، كلياتهم مست كلياتهم هيل بعدين، يعني they deserve treatment، مش زي ما بيحكوا انه ممكن انها تكون. والهيربرت سكروز يعني خبرتنا فيهم. انك ما ترجع باتيلر ديسلوكيشن هاي شوي بناقشك فيها دكتور هاشم، يعني الباتيلر ديسلوكيشن اغلبهم بيجوا راجعين لحالهم، يعني اغلبهم بيجوا انت بتعرف انه الهيستوري انه في عنده، اما الواحد جايك انه ركبته مثنيه وعنده باتيلر ديسلوكيشن يعني والركبه لوكت ان انفليكشن مش قابله تفتح لحالها ماشي، يعني اكستريملي رير. هلا الارثروسكوبي بالفراكتشرز بالاكيوت فراكتشرز، هلا بالكرونيك فراكتشرز مختلف، بالاكيوت فراكتشرز بالتيبيال بلاتو يعني او بالفيمورال كوندايلز بشكل عام، يعني في عندك الكبسول بتكون مضروبه وثرو ذا فراكتشر فبصير الانسيدنس اوف كومبارتمنت سندروم فيري هاي، وبكون السيت اب صعب لانه بدك انت بامب وبدك يعني فيري جود ارثروسكوبي سيت اب، حتى مش زي الارثروسكوبي العادي، حتى بالريست حتى بالهاي، يعني بالليترشر بحطوه بس براكتيكالي فيري ديفيكولت، براكتيكالي مش سهل، يعني احنا بنحكي انه بتشوفها بالسكوب صح سهله، بس على ارض الواقع احنا السكوب العادي في عندنا صعوبه، بيكون عندك بليدر بغلبك وبموتك وبجننك وما بتشوفش مضبوط، وفي انسيدنس اوف كومبارتمنت سندروم. ف اكيد بس يعني مش انها شيء سهل. تمام. المحاضره الاولى فيها عليها سؤال اللي حكيناها. طيب دكتور وليد يعني ايش نعمل هلا احنا؟ السكافويد هاي انا داومت بالضمان الاجتماعي فتره، يعني السكافويد السكافويد والاي سي ال، السكافويد والاي سي ال هذول من اكثر الشغلات اللي هم مشكله كبرى للضمان الاجتماعي. والسكافويد ممكن تكون يعني اللي بيجيك مرات كرونيك، كثير مرات بتكون حتى التروما مست، يعني تكون سمبل تروما ما راح وما تصور، ويجيك انت بالنيو فراكشر بيكون اصلا عنده كرونيك نون يونيون. فهلا احنا بيجينا واحد فولينج اوت ستريس هاند اللي بينظف بزحلق الى اخره، صورناه ما طلع فيها كسر، شو نعمل؟ هلا اذا دكتور عظام ولا دكتور اسنان نعمل له MRI، هاي سهله. اما نحن بنحكي عن الناس بشكل عام، يعني انت بيجيك اغلب الناس واحد رياضي وواحد طالب مدرسه طالب جامعه عسكري الكومن بيشنت.
It's difficult to give a straight answer. But the recommendation انك تعمل له MRI او CT scan. لكن اذا كان عندك ستوب لا يسمح you have two options. هلا اذا المريض كان tolerate immobilization without any harm, without any let's say financial burden عليه, put the plaster for him and send him back or bring him back in 2 weeks time. At that time, if the fracture is not clear and still is having symptoms, do CT scan now is very much justified and you have to stress it. But in my opinion, you have to diagnose scaphoid fracture immediately. And many patients, خاصة work compensation, زي ما حكيت they are a big burden على صاحب العمل وعلى السوشيال سيكوريتي وعلى كل شيء. I think it should be diagnosed immediately either by CT scan or MRI. CT scan is more accessible in many hospitals. Right? This is my opinion regarding the scaphoid fracture. You have to have an answer immediately. Yani last time I saw a case for a nurse in the hospital. She was in the same hospital. I did see X-ray. It was negative. Finally, clinically she has a scaphoid fracture. Discuss with her حط لها بلاستر ولا قلت ما بدي اعمل سيتي سكان حط لي بلاستر. اجى المسؤول قال لي لا هاي المرضى مش عندي نقص بدي اعرف انت فراكشر او لا. We have to do a CT scan على حساب المستشفى. And we did CT scan, she had a fracture and she was treated for a fracture. So it's a big difference between to leave the patient alone with the plaster or do the CT scan.
شكرا جزيلا. طيب على محاضرة الريجستريز للدكتور فراس، يعني هم الريجستريز ممتازين ومهمين، واكيد احنا في فروقات بيننا وبين اللي احنا بناخذ منهم المعلومات وحجم المعلومات كبير. سؤالي يعني بوجود التكنولوجيا الحاليه وسهوله وسائل التواصل، هل في ممكن مثلا ان الجمعيه يعني الريجستريز عاده تعملها الحكومه، يعني هلا مثلا الحكومه اكيد في ريجستري هلا للكوفيد مثلا لانه موضوع مهم، كل يوم بالجريده بنحط الوفيات وبنحط الحالات المصابه هذا ريجستري. هذا ريجستري. الكانسر في عندنا ريجستري. هلا في كثير امراض يعني اي مرض غريب عجيب بيطلع مثلا تي بي ريجستري. هلا هاي الاشياء الكومن الحكومه ما بتقدر انها تعمل ريجستري لانه بتعرف يعني بده ادمنستريشن وبده شغل كثير. هل مثلا الجمعيه او احنا كاورثوبيديك بودي نقدر نستخدم مثلا وسائل التواصل الاجتماعي الحديثه؟ يعني في اي دراسه او حدا عمل زي هيك؟ يعني مثلا كل واحد فينا بيعمل توتال هيب مثلا يبعث مسج لجروب معين مثلا توتال هيب ريبليسمنت او هيب فراكتشرز مثلا اني انا اعطيك معلومات حتى انت تعمل ولو احصائيات بسيطه جدا.
مظبوط. احنا السوفت وير مهم جدا في الموضوع، وخاصه يعني هلا ببساطه ممكن نسوي احنا ابلكيشن على الموبايل، اي واحد ممكن ينزل ابلكيشن المعلومات كامله ممكن يعطينا اياها المريض والصور الاشعه. هي الفكره مش انه الفكره انه تستندرايز، يعني انه يصير في عندنا احنا باي لو اي حاله انشغلت في البلد لازم توصلنا معلوماتها. هلا مين بده يدعمها؟ انا اعتقد ان وزاره الصحه حاليا لا تدعم شيء اهم من الريجستري، واحنا الموضوع يعني ما مش مكلف كثير، وفي شركات كثير ممكن تدعم هذا الموضوع، بس هي الفكره انه ناخذ الاوكي من الزملاء ومن الهيلث سيكتورز كلياتهم to start this project.
شركه
مظبوط، بس الشركه ما بتقدر تعطيه. هو احنا هذا اذا بندور فقط على النمبرز، بس مين اللي بده يعطيك البري والبوست اوب سكور للمرضى؟ مين اللي بده يعطيك الاكس راي؟ مين اللي بده يعطيك الكوز والفيلير؟ هلا مظبوط الشركات بتلعب دور مهم، المرضى بيلعبوا دور مهمين، المرضى ممكن كمان المرضى هم يعطوك المعلومات، بس برضه انت بدك تعاون الزملاء. الزملاء هم الكورنر ستون في الريجستري. كورنر ستون طبعا بروفايدد الزملاء اكيد راح يخافوا من الموضوع، بس هي الفكره في الموضوع انه all information سواء كان سيرجيكال او للسيرجن او للمريض كلها سكيورد. كلها سكيورد.
يا سيدي بارك الله فيكم. في حدا عنده اي سؤال او توضيح او شيء؟ الله يعطيكم العافيه. 10 دقائق بريك والله يعطيكم الف عافيه. يعني الساعه 11:38 10 دقائق يعني 12 دقيقه.
من 40 50 على 12 ل 10.
تمام ممتاز بارك الله فيك. بس بالنسبه لضيوفنا الكرام احنا شايفين جدا حضوركم اللي تمكن ربنا يسمح يضل معنا من اهلا وسهلا فيه يشرفنا ويفينا بمعلوماته وعلمه، واللي عنده اي ارتباط بعياده او مستشفى او اي ارتباط اخر بحب يغادر حتى لو كان مودريتور بالسيشنز القادمه احنا بنقطع عنه ما في مشكله. وجودكم دائما بيسعدنا. شكرا لكم جميعا.